Uh, Thank you. Thank you, Scientific Committee KSOS and Rajiv sir, for giving me this wonderful opportunity to talk to the budding ophthalmologists of Kerala. You've just listened to two wonderful talks on direct and indirect ophthalmoscopies. Now I'm going to discuss something that combines the beauty of both, that is using a slit lamp for retinal evaluation. We need to modify the optics of the slit lamp slightly if you need to see beyond the antivitreous. And the lenses we use are usually high plus lenses. That is, you can use either plus 90, 78 or plus 60. But commonly we use plus 90 or plus 78. And it's better to start examining with the plus 90. That may be a better idea, then switch to plus 78. Limited field, so it's not that commonly used now. Next slide, sir. So the advantage of these using these lenses are that you are not going invasive at all. They are all non-contact lenses, and the image you get is almost like that of the indirect ophthalmoscope. But to say an example, if you just look at every day you look at the mirror, what you see is a laterally reversed virtual image. But imagine yourself upside down with standing head on heels. That is how the inverted aspect also comes along in these plus lenses. And regarding magnification, a rule of thumb to remember would be that if you want more magnification, take a lens that is having a power that is a 78 diopter will give you more magnification than a 90 diopter. That's because of that equation, that is magnification is related inversely to the power of the lens. So actually a 90D lens gives you a 6 to 9 times magnification compared to a 60, which will give you 10 to 15 times. But this magnification actually comes from the slit lamp magnification that you are using. And if you really apply that formula, you will see what I'm talking about. It's actually the slit lamp magnification that gives you the power. Now, you may have learned direct ophthalmoscopy first as a PG, as a fresher PG. So why do you need to switch to 90D? Even if you forget the COVID pandemic, you need to switch to 90D because, as I said, it combines the magnification of direct ophthalmoscopy with the advantages of indirect ophthalmoscopy. See, the minute you switch from direct to 90D, first you feel that the image is very small. But there are definite advantages, as you will see. And as far as the patient is concerned, it's a one-stop station. You can entire examination, both anterior and posterior segment can be completed at one go. And the instrumentation is very handy. And now it's a state-of-the-art procedure for posterior pole examination. Now, in general, it's a dilated pupil that is a must for a good examination. At least a 5 millimeter dilatation of pupil will give you adequate stereopsis, and you may darken the room and draw the curtains for best results. You have to see one common mistake that is done, I always see PGs doing, is that they ask the patient to sit in position first and ask them to maintain a difficult position. And so that will make them more uncooperative by the time you actually do your examination. So first position yourself, then the slit lamp, and last of all ask the patient to be in position. So let's see how all these things are done. So these are the settings. The illumination and the oculars of the slit lamp should be at 90 degrees to the patient. You can start with into 10 magnification because that way it is easier to focus than into 16 magnification. And the intensity of the slit lamp should not be too much. Otherwise, you can even trigger a sneezing reflex on the patient. So it should be a midway intensity. The knob should be midway. And the slit beam is usually of 1 to 2 disc diameter, not more than that. Then you will lose focus. And you have to focus your beam right through the center of the pupil. Now, this is the patient positioning is as usual, but I wanted to tell you this, that is, see, when the patient is looking through the slit lamp into the light, that bright beam will be at the fovea. So if you want to see the disc first, supposing you are looking at the right eye, please ask the patient to look to your left ear so that the optic disc will come and, the optic disc will be in the line of that slit beam. So that is how you will ask the patient to first look. Finally, only you will switch to the fovea. So next, please. So the lens, as Dr. Biju has demonstrated beautifully, it should be held between the thumb and the index finger, just like he said. for all those 4 reasons. I'm not repeating it here, but one thing I must say is you should take care not to touch the lens surface with your fingers when you do it. And a rule of thumb would be, if you're using a 90D lens, it is best to keep it in such a way that the lens just clears the lash line. That would be around 7 to 8 millimeters from the eye. And always check from outside. That is, you tilt your head and check from outside like this, whether the slit beam is actually passing through the lens and then going through the center of the pupil. That alignment is very important. Next slide, please, sir. So this is how the image is formed. You get an image in between the lens and the slit lamp. You get, that is the image actually what you're seeing. Next slide, please. Now, I would advocate you to use the pullback technique of these 2 techniques. That is, first you go close to the cornea with the slit lamp and focus the cornea. Then further 1 centimeter back, you are on the fundus. So this is slightly a semi-quantitative method by which PG is initiating into this technique and use this step, whatever procedure you're comfortable with. Next slide, sir. So this is a small video just to show you how the slit lamp should be first adjusted. As I said, the oculars and the illuminating system should be 90 degrees to the patient and well aligned. And in yes, this is how the lamp is being adjusted. Yes, now the magnification should be 10 and the lens should be held in position like this using the index finger and the thumb. And you can use your middle finger to support your hand either. And as far as the intensity is concerned, it should be between the midway, it should be midway in intensity. And usual position only, you ask the patient to sit in the usual position. And these are gentle movements by which you can adjust the focus. This is what the fovea is now in focus. If you want to shift to the disc, you have to ask the patient to look into the ear. So first, it is the disc that should be examined, then the arcades, and finally the ear. Now the image, as I said, it's a virtually inverted lateral reversed image. And to record findings, you need to keep your sheet at 180 degrees, just like you would do in an indirect ophthalmoscopy. Next slide, please, sir. So now we go to some tips and tricks and troubleshooting, because you are going to get into some small trouble in a new technique. As I said, all of you would want to see bigger. And to see big, you can do 2 things. One is to increase the slit lamp magnification, or you can switch the lens to a 78 or a 60D. 78 would be better. The next problem that we see is how to maximize view, because the slit beam view is very, very small in width. So to maximize view, you can either decrease the magnification if you're in high mag, or increase the beam width and then fine focus, or you can try bringing your lens a bit closer, or scan the posterior pole. That's what we actually do. You scan the posterior pole and keep the eye stationary. Scan the posterior pole with overlapping slit beams. Next, sir. Now, light is all I see is what a PG usually experiences, the glare. It is too many reflexes are there. So what can you do to reduce reflexes? So some tips would be, next, one is decrease your intensity of illumination if you are having too much light. Tilt your lens a bit. You can try decreasing the beam width, and you can shift the illumination arm slightly off center. So all these things can give you a better image like this. Next. So this is how you have reduced the glare in the same patient. Now, this is something that can happen. You are in focus, but you don't know actually where you are on the retina. This is because the patient may have shifted his position while you were intent on doing 90 degrees. So always monitor your patient's position. Occasionally, you can see from outside also. And always keep your slit beam on the central pupil. Next slide, please. Now, can I see the, you can very well see the periphery using a 90D. So for example, if you have to see the periphery up, that is superior periphery, you have to ask the patient to look up. And you should move your lens. The patient should look superiorly. You should move the lens slightly up and tilt the lens slightly towards you. That is, the top portion of the lens should be tilted slightly towards you. And look through the center of the lens, because the peripheral retina will fall towards the center of the lens. So the gaze of the examiner should shift towards the center of the lens, while the gaze of the patient should shift superiorly. Okay, so that is how you can see the periphery, and this can be done in all quadrants. Next slide, sir. Now, sometimes you see everything, but still you see it is not that beautifully seen. So in such cases, you can dim the lights and you can optimize your slit beam centration by the slight circulatory lens movements. These circulatory lens movements are very helpful in bringing things to fine focus. Next slide, sir. So these are all the newer lenses available. You can have increased field of view, or you can even see through a small pupil. Incidentally, small pupil conditions also possible through a normal 90D, but it requires a bit more practice. So all these are the newer lenses. We have 3 generations. Next slide, sir. So we have actually 3 generations of lenses, classic and super and digital. So whatever you use, whatever lens you use, next slide, sir. It is not actually the lens that is important. It is your practice. It is practice, and more practice alone that will make you perfect. So next slide, sir. So thank you all for your attention, and I hope this will help you in some way.